Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to fill out the attendance records and also please remember to fill out the program evaluations. And if there are any future topics or speakers that you'd be interested in hearing about, please let us know. CME committee will try to make that happen. Our topic today is bariatric surgery, and we have an authority in the field, and Dr. Isaac Samuel. He is currently associate professor of medicine. He's been, surgery at the University of Iowa, and he's been extensively published in the field of bariatric surgery. He's here today to provide us with an overview. And please join me in welcoming Dr. Samuel.
Thank you and good afternoon. And I assume that most of you are from AIMS, and therefore I'll call you the AIMS group. On the other hand, I'm the aimless group. I would first like to emphasize that severe obesity is a weighty issue. And the state of Iowa used to be amongst the top 10 states in the country for obesity. Some time ago, several years ago, the state of Iowa was within the top 10 states for severe obesity in the United States. That's why if you walk around the University of Iowa, you'll hear people say, the Big Ten, the Big Ten. So today I'm going to give you quite a broad overview of bariatric surgery or surgical weight reduction. I'm going to give you some data showing that it's safe and that it's effective, explain a lot of the benefits of surgical weight reduction. And I will also compare it to medical weight management, which is the competing discipline in a way, or used to be a competing discipline. So this whole thing about safety, several years ago, it was controversial, but more recently, the safety has increased so much that it is becoming less controversial within the specialties, but a lot of people really don't know about it. So that's why we'll have to emphasize that and explain that. Now this is laparoscopic surgery. So we do a lot of our operations, for example, the gastric bypass and the sleeve gastrectomy, we do them laparoscopically. Now, back in the 60s and the 70s, all the way up to the 90s, bariatric surgery was done open. You had this large open incision here in the abdomen and in these large patients, and recovery was difficult. You had a lot of pain from these big incisions, and postoperatively you had problems like pneumonias. And one of the commonest complications used to be wound problems because of the thickness of the abdominal wall and the adipose tissue. Patients would get large fluid collections and wound infections where you had to open up the entire wound and it had to be packed and dressed for weeks before that closed. So just the surgical approach was so invasive in this particular group of patients that itself was dissuading enough. That's when the laparoscopic approach made a big difference, where with minimally invasive surgery, you put these small little ports through keyhole incisions, and there is a camera there. That's the surgeon's right hand, another port for the surgeon's left hand, and the assistant has a port here, and another one for a liver retractor. And so here the invasiveness is so much less that the outcomes are much more impressive now. Earlier ambulation, pain control is much easier. Our patients right now after a gastric bypass are going home on post-op day 1 in the evening, while previously it used to be 4 to 6 days in the hospital. So post-op day 1, they're going home. And many returning to work earlier. And then the wound infections, just minor wound infections. You don't have those horrendous large incisions that have to be left open. So it was in 1993 that the first laparoscopic gastric bypass was done, and it took a few years for that to catch on. But once people became proficient at the laparoscopic gastric bypass, because technically that's a very difficult operation, And it needs a 1-year fellowship to be properly trained. And for since 2005, we've had a 1-year fellowship training program at our program at Iowa City. And once that became accepted and more people were able to do it, there was a sudden explosion in the volume of bariatric surgery. But suddenly it became much less invasive, much safer, and the outcomes were much better. So it went to this level, well above 200,000 cases a year in this country. So this is Dr. Edward E. Mason. He was at the University of Iowa for most of his career. And in 1965, he conceived and performed the first gastric bypass. So because of that, the University of Iowa is considered the birthplace of obesity surgery, and Dr. Mason is considered the father of bariatric surgery. Because before Dr. Mason, the philosophy was the focus was on the intestine. The jejunal-ileal bypass and intestinal bypasses were what people tried before the Mason era, before 1965. But there the patients had very bad complications, where there was bacterial overgrowth and malnutrition and complications of the liver resulting in death. And people realized that with the intestinal bypass operations, the cure of the disease was actually worse than the disease itself. And it was Dr. Hutchinson in London who said, "From making the cure of the disease more grievous than the endurance thereof, good Lord, deliver us." So that exactly was the philosophy when Dr. Mason started thinking, what's wrong here? And he noticed in his clinic that patients who had gastric bypass for peptic ulcer disease found it very difficult to gain weight again. So he thought maybe we're operating on the wrong organ. And he started experimenting with surgery on the stomach. And so the anatomy is a little different in the bariatric gastric bypass as opposed to the gastric bypasses for peptic ulcer. The anatomy is quite different. But that's how he thought about it. And after that, much later, he came up with another operation called the vertical banded gastroplasty. In the year 2000, in our department, my mentor, Dr. Maher, with me helping him, we were the first to perform laparoscopic gastric bypass in the state of Iowa. Then in 2007, along with my partner, Dr. Muhammad Jamal, we became a National Bariatric Surgery Center of Excellence. Now, the Center of Excellence is a concept that was introduced in 2006 for the first time. So the problem was when the laparoscopic surgery became extremely popular, you had a lot of surgeons jumping onto the bandwagon because it was suddenly exploding. You suddenly had this explosion in volume throughout the country. And the incentive was reimbursement and RVUs and that kind of productivity rather than thinking of the patient as a patient. People were thinking of these patients as a commodity. So in effect, you had a lot of surgeons, you could call them cowboy surgeons, going to weekend courses and watch somebody operate and then trying to do this complex operations themselves laparoscopically. And that resulted in some horrendous complications throughout the country, stretching from Boston to California and even in some parts of Iowa. You had some horrendous results where there was a high mortality rate and people who survived would have severe complications because leaks were missed and they were in sepsis. They go to a systemic inflammatory response syndrome with multi-organ failure. They're in the intensive care for weeks. And suddenly, bariatric surgery got a bad name because the press, as you will know, will put in headlines only when things go very bad. That's when bariatric surgery was in the headlines, when things went very bad. So the people with good results were not focused on at all. So when bariatric surgery got this bad name from these cowboy surgeons trying to jump onto the bandwagon, the Society for Metabolic and Bariatric Surgery realized that we need to take control of this. And they said what we need is we need to create centers of excellence where the surgeons prove themselves. First of all, they undergo adequate training, and then they do at least 100 or 150 cases, and they prove that they have decent outcomes, safe outcomes, and only then should a program be allowed to perform the surgery as a center of excellence. So that was the philosophy. So we think that was a very good idea, and it is spread throughout the country, and the American College of Surgeons also has been involved in this, and Medicare has also recognized the center of excellence. So here's a long list of the comorbidities associated with obesity. And I'm sure most of you will be familiar with a lot of these, but here's a full list and an even more detailed list. And the more you look around in the literature, you will find that significant weight reduction, whether medical or surgical, can resolve the majority of these comorbidities. And the difference between surgical weight reduction and medical is that the surgical weight reduction is much more effective. For example, way back in 1992, this classic paper, Goldstein, they showed that medical weight management, not only is it not as effective, it does not last. Within 1 or 2 years, the majority of the patients regain their weight. So based on that paper, surgery became more important. So I'll briefly describe the anatomy here. So for the gastric bypass, you create a small pouch by stapling across the stomach here. And then the bowel here is cut across by stapling here. This distal end is taken up and hooked up to the small pouch. And here, the proximal end is hooked up as an anastomosis here to maintain continuity. So you have the gastric juice, bile, and pancreatic enzymes going down the duodenum and down the jejunum without mixing with food. While here, you have the food going down without mixing with the digestive enzymes and bile. So that is the malabsorptive portion of the operation, where this is about 75 centimeters, while this is about 30 centimeters, so about 100 to 105 centimeters on the whole of malabsorptive component. While this is the restrictive component, where this small pouch makes the patient feel full quite early. Another operation is the sleeve gastrectomy, where here you just staple across the stomach completely like this, and you resect this. So the remaining stomach, which is about 20% of the original volume, is typically described as a banana-shaped organ that's left behind. So this is purely a restrictive operation. And people tend to do this sometimes as a two-stage procedure where you have such a high BMI, like a BMI of 70 or 75, where the laparoscopic surgery can be technically difficult in those patients sometimes. You do it as a first stage, then later on you can go and convert this into a gastric bypass after the patient has lost a significant amount of weight. And then finally you have something else called a band, and I'm sure all of you would have heard about the band because it has been marketed so much. And this is the adjustable gastric band, where you have a port placed subcutaneously, and the port can be injected after access with a syringe, injected with fluid, where this band expands and the restriction increases as you increase that. The problem with the band is anytime you put a foreign body inside the human body, there are problems. Either it slips, or it herniates, or it erodes into the stomach, or it gets infected. So with time, it has become more and more unpopular, especially after the laparoscopic sleeve gastrectomy took off in popularity over the past 3 or 4 years. The band is kind of going into disfavor. I call it the band on the run. So here's a paper from 2007, New England Journal of Medicine. It's called the SOS study, or the Swedish Obesity Subject Study. So they showed that mortality is reduced by surgical weight reduction. So, so this was a pretty impressive study. You had 2,037 patients who had conventional treatment, and 2010 that had surgical weight reduction. And so this was a matched control group, and they compared the surgical group and the medical group. So there were 129 deaths in the control group and 101 in the surgery group, and this difference was significant. So they concluded that the most common causes of death were myocardial infarction and cancer, and both of these were improved, with mortality improving. And then you have another study. This is from Utah, also New England Journal of Medicine, 2007. And here also they had the same results, where mortality was significantly improved in this group also. Now here the controls were severely obese persons who applied for driver's licenses. And they had one more conclusion, that the rate of death from causes other than disease was higher in the surgery group than the control group, and the commonest cause was accidents. So people dying from accidents was higher. So this study was criticized because the control group is not a well-balanced group for the surgical group. For example, if many of these patients did not get their driving license, then they wouldn't be driving, and then they would not have accidents. And another well-known study published in the New England Journal of Medicine in 2012 is a study showing that surgical weight reduction, which is either the laparoscopic sleeve gastrectomy or the laparoscopic Roux-en-Y gastric bypass, compared to intensive medical treatment, the surgery was much, much better. If you look at the complete remission, with intensive medical treatment, there was zero complete remission of diabetes. Well, with the gastric bypass, it is 42%. With the sleeve gastrectomy, it is 26%, where complete remission is described as hemoglobin A1C below 6.0, and they're euglycemic without medications. So that is pretty impressive. And this is one situation where the boundaries of bariatric surgery started expanding, where people started saying it's not only weight reduction surgery, it's also helping to cure other diseases. So then people started introducing the term metabolic surgery. So the society renamed itself as the American Metabolic and Bariatric Surgery Society. And you will have a lot of endocrinologists throughout the country who are up in arms saying, no, surgery is too risky, insulin is much safer. But with time, the safety of laparoscopic bariatric surgery has increased, and the society and the American College of Surgeons have shown that. So this is my personal series of gastric bypasses since 2003, and I've done a total of 500 cases. This is until about April of 2013. And as you can see, I've had no mortality at all in my entire series of 10 years with 500 patients. And my 30-day readmission rate was pretty low, and most of them had small problems that did not need an operation. Over this entire period, only 3 patients needed an operation, and all of them did pretty well. And 2 of them were laparoscopic, and that's 30-day reoperation. Anastomotic leaks, which are considered dangerous, I've had none for several years and only 4 throughout the period, which gives 0.8% leak rate. And many of these did not need a reoperation. I've controlled them without a reoperation. Only 1 DVT, only 1 pulmonary embolism, minimal wound infections, and these were related to the JP drain. And incisional hernia 0, while with the open surgery, almost 1 in 3 patients get large ventral hernias. And pneumonias 0, while that was a big problem with the open surgery, where patients had pneumonias and problems related to that. So back in April of this year at the University of Iowa in Iowa City, they had something called a mini medical school series, where over a period of 3 weeks, you had speakers talking on the topic of obesity. So on April 16th, there was a speaker who spoke about the medical weight management. The following week, on the 23rd, I gave a rebuttal to his presentation. And his presentation, I would say, was pretty extreme. And just to be polite, I'll just call him Dr. Pusher. Let's say Dr. P. Pusher. So P stands for pill pusher. So Dr. Pusher, he was pushing his line of specialty, and he was saying that drugs are both safe and effective to this degree. While surgery, he put it down here. He said it's very effective, more effective than drugs, but he put it all the way down here as unsafe. Now, I would say this is very old news. This is from the previous century. This is from the 20th century, not the 21st century. The laparoscopic era has changed this completely. And for a specialist to come to the University of Iowa and present this kind of data and concept about surgery, I would criticize that a lot, because the University of Iowa is considered the mecca of bariatric surgery. And as the birthplace of bariatric surgery, it would be the Bethlehem of bariatric surgery. And Dr. Mason himself would be the holy Buddha of bariatric surgery. And all his writings, all Dr. Mason's writings over a period of time, his body of literature could be considered the Ramayana of bariatric surgery. So to come to the University of Iowa and have such an extreme presentation about bariatric surgery, I would complain about. So I would say, pardon me, sir, but which surgeon was doing your cases? And then he went on and he talked about the perils of bariatric surgery. And this is also really old news, in that the dumping syndrome is really non-compliance. If people take high-density foods, either sugar or lipids, which you're not supposed to do if you're compliant with your post-bariatric surgery diet, then you will not get dumping syndrome. So the non-compliant people get dumping syndrome. So on our program, we hardly see this at all. Anastomotic leaks, it's really come down a lot with the laparoscopic approach. And we've reached a stage where on our program, we control these non-operatively. Incisional hernias, you saw my slide, 0. You have these keyhole incisions that seal up well, and you have no hernias at all. This is the old open surgery approach. Infections, minimal, just JP drain infections. No going and opening a whole wound and packing it for 2 months. No, old story. Metabolic bone disease, there is some reduction in the bone density, but we have a publication that shows that after 1 year, it stabilizes. Suicide, I have a separate slide about that topic. Hypoglycemia, this happens in something called nisidioblastosis, and it's very rare. The Mayo Clinic had a series of just 6 patients, and it is my belief that the nisidioblastosis syndrome, where you get islet cell hyperplasia, that happens only in certain patients where they have extreme malabsorption, where the length of the bypass is too much, which most people don't do. And 40% complication rate, this is again from the previous century. And mortality rate, the American College of Surgeons have shown that with the centers of excellence, it's even less than this. And there are many surgeons in the country who have a 0 mortality rate. So talking about the suicide story, there was one paper which indicated and concluded that there is a higher incidence of suicide among patients who have bariatric surgery. But then a year later, there was another paper that followed up on that, and these authors had a better control group. The control group in the first paper was the normal population, age matched and gender matched. So there was no control group where there was morbid obesity without bariatric surgery. So in this paper, they did that. And here they showed that it was the same in the 2 groups. So the control group had to be a morbidly obese group without surgery. And they found that it was the same. So morbid obesity itself is a risk factor for suicide, not the surgery. We therefore consider it unlikely that the excess in suicide deaths we observed was related to bariatric surgery. That was the conclusion. And then, so that's my series there. And if you compare it to a lot of published papers, you'll see that it's either equal or better. And then we have a series of studies where we kind of expanded the frontiers and showed that there are added benefits of bariatric surgery. And this was one novel study. And this paper was quoted in the Science magazine, where they have a Science News magazine section of the Science magazine. There was an article about bariatric surgery and its benefits. And this paper was quoted by them. So in 102 patients who had migraine headache out of our entire cohort of 702, we excluded 21 because they had too short of a follow-up. So out of the remaining 81 patients, there was an 89% improvement, and the excess body weight loss was 56%. No improvement at all was only 11%. And here, complete resolution in 70%, and partial resolution in 19%. So this is a pretty impressive number for migraine headache to go away. So of course, you're going to ask me how? Migraine and obesity, how? Well, actually, there were already some studies in the medical literature saying that medical weight management helps patients with migraine. And in the clinic, I should tell our patients, if your migraine headache came after you gained your weight, there's a better chance that your headache might go away. And I was just guessing when I said that. So finally, when we looked at it, we studied it, and we asked the patients individually, which came first, the obesity or the migraine. So we found that patients who had the migraine headache before obesity onset, there were 24 of them, while if the obesity came first and migraine headache came later, there were 51 of them. And this is what we found, that there was total resolution of 80% in this group, while the total resolution was only 46% in this group. And this was significantly better than that. So there's an obvious relationship between obesity and migraine headache. And you might ask me why. Well, the hypothesis is that adipocytes have a cytokine burden, and therefore in morbid obesity you have an excess adipose burden, and therefore the cytokine burden is higher in these patients, and therefore patients who are predisposed to migraine, if they have excess weight, the cytokines will exacerbate the problem or bring it on. So partial resolution 14% here and 29% there. So conclusions, weight loss following Roux-en-Y gastric bypass significantly resolves migraine headache in the severely obese, especially when migraine onset is preceded by obesity onset. And then another paper of ours looked at polycystic ovarian syndrome. So out of 566 females over almost 10 years, there were 20 with PCOS who had more than 12 months of follow-up. Out of these 20 patients, 2 did not desire pregnancy, and 8 of them were able to conceive before gastric bypass. 3 of them needed hormonal treatment. And then you had 10 who did not conceive before the gastric bypass. 6 of them had sought medical treatment for it. After the gastric bypass, all 6 who desired pregnancy and who had tried medical treatment before, all 6 conceived after gastric bypass without hormonal treatment. The remaining 4 no longer desired pregnancy. So in other words, out of the patients who desired pregnancy, there was a 100% conception rate after gastric bypass and successful weight reduction. And in addition to infertility, hirsutism improved and menstrual dysfunction also improved. Clinical improvement in symptoms of PCOS was seen in majority of study patients, with all patients desiring pregnancy able to conceive following surgical weight loss. Another publication of ours was about hyperlipidemia in this group. It is a risk factor for atherosclerosis and coronary artery disease. It's present in more than 50% of our population, the severely obese population. And it fails to show clinically significant amelioration with medical weight management methods. So over a 5-year period, we had 248 patients with Roux-en-Y gastric bypass, and they were followed up for 6 months post-op and then annually for 6 years. And that is some of the numbers, 20 males, age range 25 to 58, weight 216 to 460 pounds, BMI 36 to 78 BMI. So percentage excess weight loss, 50% is considered a success. And so within 6 months, they were reaching there, and by 12 months, they were there. And at 6 years, the number of patients followed up was a little low. Total cholesterol, it came down within 6 months and stayed below 200. Triglycerides came down within 6 months and stayed below 150 for the entire 6 years. And LDL also came down and stayed below. While HDL, which is the good cholesterol, went up and stayed up, while the patients on medications came down substantially. The Roux-en-Y gastric bypass results in significant resolution of hyperlipidemia associated with severe obesity. The improvement in hyperlipidemia shows an early impact by 6 months and also a long-term benefit up to 6 years of our follow-up. And this 6-year follow-up was the longest published study at that time. So we come back to Dr. Pusher's slide now. In his talk later on in the slide, he showed this slide again, and he was being overtly optimistic about medical weight management and pretty pessimistic about surgical weight management. So you will notice that his small circle suddenly became a big circle, and it's up there, like it's put on a lot of weight. In the earlier slide, it was much smaller. And then the surgical circle has increased in safety, but it's still below that safety line out there. It's still below there. And it's become small, like it's lost a lot of weight. So in reality, this should be above that line based on modern data. This is from the previous century. Based on modern data, it should be up there because even pills have their own complications and can be unsafe. Everybody knows about the stories with fen-phen and heart problems and mortality. Everybody knows all those stories. And in his talk, he actually said, if you give Synthroid, that'll help in weight loss, but you can die. So is that science fiction? That drugs are going to be that effective and are going to be the majority, most of the patients going there for that treatment? Unlikely, because the hormones have been known for so many years. For more than 50 years, most of these GI hormones that affect obesity have been discovered. Leptin, GLP-1, ghrelin, all of them were known long ago. And until now, we've not had any drug that works well enough. And therefore, to say by 2020, this is where you're going to be, it's actually the other way around. Surgery is becoming much more popular, and this is still ineffective. So to say in 7 years it's going to happen, that's quite an exaggeration. And about surgery being down here is fiction. The number of patients here is going to be much, much larger by 2020. And I wonder, did he mean 2,200? Was it a typo, a typing mistake? So this is a couple that came to my clinic, and I operated on both of them. And if you look at the family, one of the biological sons has the problem, while 2 biological children don't, while 2 adopted children who share the same environment don't have the problem. So this is quite a complex situation. And this is the same couple post-gastric bypass. So his numbers, within 1 year, his BMI went from 42 to 30, and he went off his anti-diabetic and antihypertensive medications. While her story, within 2 years, she went down from 49 to 28 and went off all her medications. This is another patient, BMI of 43, worked as an accounts manager, borderline hypertension, also had reflux, stress incontinence, and irregular periods. And she's actually one of the 6 who successfully conceived post-gastric bypass. She lost 120 pounds and gained a husband. BMI down to 22, which is normal. Normal range is 19 to 25. 22. She is very compliant. All her comorbidities went away. And 3 years post-op, she had a healthy baby boy. So these are examples of how important the impact is on the life of these patients. It's not just a question of weight reduction. It's quality of life, and it improves your body image, it reduces your comorbidities, and it is a life-changing event. Her future is diametrically opposite to what it was before her gastric bypass operation. Obesity begins at home. And that is why in my own home, I try and teach my children from the beginning about good diet and good exercise. For example, these are my little kids. This is a few years ago when they were 2 years old. This is Simon. He's a biological child. This is Rachel. She's adopted from China. So obviously she has Chinese genes. Simon has no Chinese genes except his Wranglers that are made in China. And they have totally different eating habits. Simon will run around. He will not sit in front of a plate and eat. You have to keep catching him and pulling him back to his plate. While Rachel is very focused at the table. If you put a plate in front of her, she'll sit there, she'll hardly talk, she'll eat, and in 10 minutes, a plate is empty, and she'll ask for a second helping. And then she'll finish a second helping. And after a while, I look at Simon's plate, and Simon's plate is empty. And I say, hey, did Simon finish his plate? Because that's quite unusual. And Rachel says, no, Daddy, I finished it. So thank you very much. I will leave some time for questions.
Do you have specific criteria for inclusion or for evaluation for bariatric surgery? BMI
yes.
or previous failed attempts?
Yes. In 1991, the National Institutes of Health came up with criteria for the whole country. And that 1991 conference was an important conference because that's when the NIH made a formal statement that obesity is a disease. It's just not a behavior problem, it's a disease. And they came up with the NIH criteria, which are followed until this day. Body mass index of 35 with significant comorbidities, for example, diabetes, hypertension, and where exactly that line is drawn to define comorbidities, it varies between different insurance carriers. While BMI of 40, even without any comorbidities. So 40 and above or 35 and above with comorbidities. And also they say more than 100 pounds of ideal body weight or double your ideal body weight. All these are criteria. And a lot of insurance carriers nowadays insist on a documented failure of medical management. Some of them want it for 6 months, some of them want it for a shorter time. But we used to do that in our program even before. We used to use that as a way of coaching them preoperatively, where if they're coached well preoperatively, then they will do better postoperatively. Yes?
Yes, I work at the mental health center, and there's a number of morbidly obese patients there. Several have had a stomach stapling and are trying to get their second stomach stapling. What are your guidelines about that? On the whole, that's called revisional surgery. And the way we go about it is there really a mechanical problem with the first operation that needs correction? So if we investigate these patients and find that the surgical anatomy is fine, there's no problem, then it's really a failure of compliance. And those patients you should not be operating on. We send them back to the dietitian and say, go back to your diet and exercise. That's what's wrong. If you do that right, you have a better chance. While if we find a mechanical problem, for example, in a vertical banded gastroplasty, you can sometimes see the staple line has burst open. Sometimes it happens during pregnancy, and then that results in weight regain. Some people used to do an undivided gastric bypass, where that staple line would break down, and then your pouch is communicating with your stomach, and then your bypass is completely gone. So in those patients, we reoperate. So I do quite a lot of revisional surgery on my program, and we do it laparoscopically. And we've converted vertical banded gastroplasties to gastric bypass, either because the staple line broke down or because the channel became too tight and they were having reflux and nausea and vomiting, things like that.
Yes?
Question. Is there well, I presume there is, but can you elaborate on the effect of age and the eligibility of patients as they age? And tied to that, is Medicare paying for this?
Yeah, there used to be a 65 years cutoff line, but that has changed. The American Society for Metabolic Surgery came out with data showing that it can be safely done even above the age of 65. So that 65 age limit has been removed. Medicare in 2006 gave an official statement that bariatric surgery is justified, and they do cover it. And they had a rule for a while that bariatric surgery for Medicare patients should be done only at centers of excellence. Right now, that's a little controversial, where some of the surgeons have gone and presented data that even we can do it safely, so you should remove that rule. So Medicare is considering that, but the society is going back, and so there's a state of flux right now. But Medicare does cover it, and they recognize it.
If you had a patient with morbid obesity, history of previous pulmonary infarction, clotting defect, and on high levels of Coumadin and morbid obesity and diabetes, would you do surgery on that patient?
We have done several patients with previous PEs on Coumadin. We've done it safely. We stopped the Coumadin 5 days preoperatively, and post-op, when they're discharged, they start taking Lovenox at home. While in the hospital, they're on subacute heparin, and we continue the Lovenox for 2 weeks.
Thank you.
In fact, next week I have a patient like that. She's stopping her Coumadin on Thursday, and on Tuesday and operating on her. Yes?
Some of those patients with migraine headaches may have had, some of the migraine patients with migraine headaches may have had undiagnosed pseudotumor cerebri, and the weight loss would then have helped that as well.
Yeah, there's a very detailed discussion in my paper on that, because the reviewers brought up the same thing, and I went into a big discussion about that. So one thing is that our patients were all physician-diagnosed migraine headache. Like, we were not just labeling them as migraine just because they have headache. Mm-hmm. So in the pre-op evaluation, we have different boxes checked. Mm-hmm. You know, we have a box for like frontal headache or other headaches, and we have a box for pseudotumor cerebri, and we have a box for migraine headache. Okay. In addition to that box being checked, we checked to see if those patients were on anti-migraine medications. Because if a neurologist or a physician put them on anti-migraine medications, they should have been responsible enough to exclude pseudotumor cerebri. Uh-huh. But that is an important question, because sometimes it's very difficult to differentiate the two. And to do a prospective study to investigate that, you'll have to do invasive studies, like a spinal pressure measurement, which is too invasive to be practical. Mm-hmm. So that could be an unanswered question for a long time. But the way I answer the question in my paper is, we came up with a separate a list of patients who were diagnosed as pseudotumor cerebri, and those patients there was no overlap in that group and our group of migraine headaches. There was no overlap. So we had a separate group of I think it was 11 or 12 patients who had pseudotumor cerebri. Mm-hmm. One of those patients actually had optic nerve compression, and she had visual field defects, and within 3 months her vision came back completely. And prior to that, she had neurosurgery to have optic nerve decompression, which did not work. But weight reduction, within 3 months, it worked.
Thank you.
Sure.
What do you see as the major barrier? Is it insurance requirements, concerns about patients, but why wouldn't more people have bariatric surgery?
I guess insurance coverage is one. Another is a lot of patients take some time to decide on it. Many of our patients who come to the clinic have been thinking about it for 3 years or 6 years. Some patients are told by their physicians to consider it, but they walk away. They think it's too extreme. So there are a lot of individuals who might not get it done at all just because they think it's too extreme. But views are changing. More and more physicians are encouraging the patients to have it done. Just last week in clinic, I had a patient who said, 3 years ago, my physician said, don't go for bariatric surgery, it's too dangerous. While a month ago, he told me to come and attend your program, because he says now he thinks it's safe with the laparoscopic approach. It's safe, and therefore now he recommends it. So the same physician who did not recommend it 3 years ago has now changed his mind. So part of it could be even exposure to the physicians about the latest technology and outcomes.
I just have 2 questions, and I may have missed this in the beginning, but as far as the percentage of patients that you do as Roux-en-Y's versus the gastric sleeve, what percentage would you say that is?
In my practice, I would say it's more than 90% gastric bypass. I do have an inclination towards the gastric bypass. My feeling is that you get more weight loss with that, and long term, it has been established with long-term data. With the sleeve, my problem is it's purely restrictive, and we do not have long-term data as to what will happen to it, say, 10 years or 20 years down the line.
Okay.
It could expand and become a full stomach. Like history has shown us in the past, like when they were figuring out how to do the vertical banded gastroplasty, initially there were restrictive operations without a band, and those operations, the restriction with time went away, because the stomach is, after all, elastic like a balloon. It will stretch if it is blown into.
And then my second question is, if we refer patients over to you, what is your protocol for a follow-up afterwards? How long do they see you or a team of people following the surgery?
Post-operatively, we see them within 5 to 7 days for the drain removal, then at 1 month, and then 3 months, and then 6 months, and then 12 months, and then once every year. And we have a open door policy where we encourage patients to come as long as they plateau and are stable. And if they want to come to us for the rest of their lives, our door is open. So I have a patient from Malaysia who flies in once a year to see us.
Thank you.
On our program, it has been 18 years. And the American College of Surgeons also differentiates programs that can do 18 years and above or below 18 years. So there are certain groups in the country that do bariatric surgery in adolescents. I think in our situation, it's more an insurance issue, where many times we are contacted, and rather than shut the door and say, no, we don't see kids, instead what we do is bring them to a clinic. We'll try and help them. And we have a dietitian talk to them. And if we try and work them up towards surgery, it's usually an insurance problem. The family does not have the coverage for the individual to have surgery at our institution. And our institution insists on pre-approval before this procedure can be done. So, but there are programs in the country where they do it. And I've heard of 12-year-olds getting it done. I mean, if you're 12 years old and 450 pounds, then you need help, you know.
I'm really sorry I missed most of this talk. Can you give us your thoughts and just sort of attitudes about societal intervention, Bloomberg's banning of, the enormous sugar water beverages and that component of our obesity epidemic?
Yeah, I think it's a good idea to remove the pop cans from schools. I think that's a good idea, because as kids, if you develop bad habits and if you drink 10 cans of pop a day when you're a kid, that's a problem. Such habits linger and you get addicted. And people have come up with the numbers of that. Even 1 can of pop a day, I'm not supposed to use trade names, that's why I'm saying pop. If you calculate the calories, that can amount to 10 pounds in a certain number of years. And before you know it, you're 50 pounds above your ideal body weight, which is already a problem. Okay. Thank you.